How's it going, guys? Cardio Pharm and Dyslipidemias for USMLE. Okay, so I'll quickly jump through the dyslipidemias, not lengthy, and then I'll do some Pharm. All right, so hyperchylomicronemia is the answer on USMLE. If they tell you milky plasma, creamy plasma, it's probably 4 out of 5 questions it shows up. Okay, they'll literally just say that in the vignette. And what they're going to do is just they want the mechanism. Okay, deficiency of apolipoprotein C2 or lipoprotein lipase. You don't have to obsess over the whys about everything. Okay, lipoprotein lipase is the enzyme that allows triglycerides to move from the blood into the adipocyte, and apolipoprotein C2 is a cofactor for lipoprotein lipase. So you're going to have increased chylomicrons and TGAs. So they want you to know as a factoid for hyperchylomicronemia as well as hypertriglyceridemia, which I'll talk about, that you can get pancreatitis. It's just one of the things they'll ask. Okay, so I said 4 out of 5 questions. They'll ask for the mechanism, as I wrote above here, but then maybe 1 out of 5, they'll say, what are you most likely to see in this patient? Chest pain's wrong. Answer is abdominal pain. Okay, so pancreatitis way more likely than MI. It's also autosomal recessive, but USMLE doesn't give a fuck about the inheritance pattern for hyperchylomicronemia and hypertriglyceridemia. What they care about is the inheritance pattern for hypercholesterolemia, which is AD, and it's going to result in decreased expression of LDL receptor on hepatocytes. That's the main mechanism. Okay, some students watching this will say, oh, but can it be other mechanisms, XYZ? Doesn't fucking matter for USMLE. Okay, it's going to be decreased expression of LDL receptor on hepatocytes. So basically 99+% of cases, because it's AD, it's going to be autosomal dominant where we have heterozygous. Okay, most cases heterozygous, and they'll just give you death by MI in 30s, 40s, homozygous, death by MI in high school. Okay, so they can give you a question where they just say LDL in the 500s, and then the answer could just be decreased expression of LDL receptor on hepatocytes. Very passable, very easy. As I just fucking said, okay? And xanthomas are non-specific. Just triglycerides / LDL accumulation. You can see them in all of the dyslipidemias, xanthomas. As I talked about, so some students might mention ApoB100 deficiency as a possibility, but I haven't seen evidence that USMLE cares about this. Hypertriglyceridemia. So the mechanism they want is increased hepatic production of VLDL. What they're going to do is give you a patient who has the lab report will say that LDL is normal. So LDL in a 40 to 75-year-old should be under 100. So they can give you LDL, which could, let's say, be 112. Okay, so slightly elevated compared to what it should be, but not eventful. And then they'll just say that TGAs are like 500. Okay, so above 300 is when we give fibrates, which I'll talk about in this presentation, but they'll give you an LDL that's not significantly elevated or normal, and then they'll give you elevated triglycerides, and the answer is just increased hepatic production of VLDL, whereas other answer choices, such as deficiency of lipoprotein lipase, you're like, oh fuck, like, is that the answer? No, that was hyperchylomicronemia. Okay. So pancreatitis, once again, same as hyperchylomicronemia. Xanthoma is non-specific. You're not going to choose MI for this. Now let's get into some Pharm. What I'm not going to do is what bullshit school medicine lectures do, where they go on a long, rambling discussion of every little detail about every little drug, because USMLE doesn't give a fuck, okay? So this is just about getting you points. So verapamil is a non-dihydropyridine calcium channel blocker. It acts on nodal calcium channels. This is in contrast to dihydropyridine calcium channel blockers such as nifedipine and lodipine, which I'll talk about, which act on arteries / arterioles instead. So verapamil causes constipation, exceedingly high yield, especially when you get to 2CK family medicine stuff, for those of you studying 2CK right now. And USMLE doesn't care about the use case. I'm just telling you here because for some of you, when I give more context, it helps you remember. You say, okay, verapamil, non-dihydropyridine calcium channel blocker, cause constipation, but like, when would we ever use that? It's not for hypertension. Well, it can be used in atrial fibrillation sometimes. Okay, patients on a beta blocker, if that helps you remember the drug overall. Now, nifedipine, the dihydropyridine calcium channel blocker, this is going to dilate arterioles, decreases peripheral vascular resistance, decreases blood pressure. And then in terms of physio, heart rate would go up to compensate. And unlike verapamil, which causes constipation, nifedipine, amlodipine, they cause peripheral edema. Exceedingly high yield. I've made lots of YouTube clips talking about this stuff, where when we think about all the different causes of peripheral edema, you got to make sure you check the patient's drugs. Okay, so it's used for USMLE, and some of this stuff is level 301, medicine 301, where nifedipine, a dihydropyridine calcium channel blocker, or a thiazide, such as hydrochlorothiazide, these two classes of agents are used for hypertension in patients who are pretty normal, just essential hypertension. In other words, they don't have prediabetes, diabetes, they don't have any evidence of atherosclerotic or heart disease. Okay, it's just 55-year-old white dude who's a little bit overweight, who's got high systolic blood pressure, no other findings, sugar is completely normal, okay? And you can start on nifedipine or hydrochlorothiazide. And I'll talk about this more as we move through the presentation. It sounds difficult at first and nitpicky, but you're going to start to see some patterns where it'll make more sense. So you can also be peripherally aware that dihydropyridine calcium channel blockers can be used for pulmonary hypertension. So nifedipine, bosentan, endothelin 1 receptor antagonist, okay? Those two drugs they like for pulmonary hypertension. You can give it as a hypertensive drug in pregnancy. It can also help, and I didn't write it in this presentation, but it can also be used in Raynaud phenomenon. Okay, so in Raynaud phenomenon, you'd avoid vasoconstrictors such as alpha-1 agonists, and you can give dihydropyridine calcium channel blockers such as nifedipine as a treatment. So beta blockers could be an extremely lengthy discussion. So beta 1 you need to know is on myocardium. Agonism will stimulate inotropy, chronotropy. Okay, inotropy, contractility, chronotropy, heart rate. Beta 2 is on peripheral arterioles. If you agonize it, you're going to dilate. Okay, so it doesn't take a rocket scientist to figure out that if you block them, okay, so you'd slow heart rate, you'd decrease contractility. If you block beta 2, you're going to decrease dilatation of peripheral arterioles, okay, decrease diameter. I'm not saying vasoconstrict because I'm just being technical about terminology. It's not active vasoconstriction. It would just be attenuated or decreased vasodilation, all right? So this is what USMLE cares about 99%. Some students say, oh, but like can't they, beta 2 do insulin release and all this other stuff? USMLE doesn't give a fuck, okay? You're talking very rare type of stuff on the exam, especially now that it's pass-fail. It's not going to show up on 2CK. So there's a mnemonic you could be aware of for the beta 1 selective beta blockers. Okay, some students remember that the letters that are in the first half of the alphabet tend to be beta 1 selective, such as atenolol, bisoprolol, esmolol, acebutolol, metoprolol. Okay, it's nothing to get fanatical about. There's many beta 1-2 non-selective blockers, but propranolol is the one that's important for USMLE. Okay, so as long as you know propranolol is beta 1-2 non-selective, and then you know metoprolol is beta 1 selective, that pretty much is like the vast majority in terms of what they care about, apart from the beta carbidiol, which I'll mention right now. So these, notice, don't end in O-L-O-L. Okay, so labetalol, A-L-O-L, carbidiol, I-L-O-L. These have antagonistic effects at both alpha-1 and beta-1. Okay, so you got to know those two. Those are very high yield. As I talked about already, beta-1 antagonism is going to slow heart rate. But what this is going to do is also increase diastolic filling time. So the slower the heart rate, the greater the fraction of the cardiac cycle spent in diastole. Okay, so this can increase left ventricular end diastolic volume. And then you might, as a student, you're very astute, you say, well, if we're increasing left ventricular end diastolic volume, that's increased preload. Wouldn't that increase oxygen demand? You're right. But the decrease in oxygen demand due to the negative chronotropy and inotropy, the net effect is actually still a reduction in oxygen demand, okay? So, and that's in contrast to nitrates, for instance, where nitrates are going to dilate veins, which will decrease preload. So that decreases oxygen demand in the myocardium. But as compensation, there's going to be increased chronotropy, inotropy. So you'd say, well, wouldn't increased inotropy, chronotropy increase oxygen demand? Yes, but the decreased oxygen demand from the dilation of the veins due to nitrates far exceeds the former. So overall, we have a decreased oxygen demand. So as I already talked about, the slower your heart rate, the greater fraction of the cardiac cycle spent in diastole. And USMLE has this as one of the answers. It's slowing the rate of diastolic depolarization, which some students find confusing. I mean, it's not so abstract if you just know that if you're slowing the amount of time you come out of diastole, then you're going to spend a greater fraction of time in diastole. Okay, so beta law, mainly 2CK stuff. When we talk about when it shows up as an answer for use case, for the step 1, they want you to know it's an alpha 1, beta 1 non-selective blocker. For 2CK especially, in step 3, they want you to know that it's first line in aortic dissection, traumatic rupture of the aorta, then choose nitroprusside after. And then I'm just letting you know there's a question floating around where esmolol plus nitroprusside together as the answer is what they want. And I'm just mentioning it because if I don't, I'm going to get a DM at a future point in time where a student says, oh, but you said labetalol was, yes, labetalol 14 out of 15 times, but just be aware esmolol and nitroprusside together is an answer floating around somewhere. And then there's other miscellaneous uses for beta blockers, such as topical beta blocker, timolol for glaucoma, okay, decrease aqueous humor production. So propranolol, this is basically the highest yield beta blocker in USMLE if I had to choose one, and it's because it has many use cases. So it can be used as part of treatment of hyperthyroidism, okay, because it decreases peripheral conversion of T4 to T3. So for example, thyroid storm, they like to give propylthiouracil. They'll give steroids for the protosis. They'll give potassium iodide to shut off the thyroid gland, Wolff-Chaikoff effect. And they'll give propranolol to slow the heart rate, but also because decreased conversion of T4 to T3 inhibits 5-deiodinase. Akathisia, that's restlessness as part of extrapyramidal side effects for antipsychotics, okay? So just be aware that you can use propranolol for that as a treatment. Lengthy discussion for all these points here. So regarding tremors, it's not just the treatment for essential tremor. So some students will say, okay, propranolol, that can be used for essential tremor. It's an autosomal dominant condition. It's a bilateral tremor, and patients will self-medicate with alcohol, which decreases the tremor, and propranolol is used. But it's not just for essential tremor. Like there's NBME questions floating around where there's a patient with history of alcoholism who has a tremor, and propranolol is the answer for the tremor. Okay, so just idiopathic, it can be attempted, propranolol as potential treatment. Social phobia, so that's going to be stage fright. Okay, so stage fright, you can also use atenolol. It's not limited to propranolol, but propranolol is a typical beta blocker that's given for it. Don't confuse social phobia with specific phobia, such as fear of flying. Specific phobia is treated with a benzo. Okay, someone's getting on an airplane, you can give them a benzo for the flight. Okay, it's like giving them alcohol. But for stage fright, you give a beta blocker. However, there's a 2CK form where they give you a patient who has asthma, and the answer is benzo over propranolol. It's a 2-set question where they ask the same fucking question back to back. One guy doesn't have asthma, it's propranolol. The second guy has asthma. Both questions are stage fright, social phobia. The guy with the asthma is getting it the benzo, okay? So it's the same question they ask, just different answers. And then hypertrophic obstructive cardiomyopathy. These patients have worsened left ventricular outflow obstruction with less volume in the heart. So if you slow the heart rate and you increase preload end diastolic filling, then you can help mitigate the murmur. And so that's another use case for propranolol. Okay, and then I'm just simplifying it here in terms of arrows for you guys, where we said increased left ventricular end diastolic volume, we're decreasing cardiac output because of the decreased chronotropy and inotropy, and then we're increasing peripheral vascular resistance. Now, why would that happen? It's because we said beta 2 will dilate peripheral arterioles. So if we knock out beta 2, then we're going to have decreased diameter of peripheral arterioles that increases peripheral vascular resistance. And then the beta law, and I put a spacing between them because I really want you to see this separation here, which is we said that Beta blockers, so the negative effect on beta 1 is going to increase left ventricular end diastolic filling and decrease cardiac output. But holy shit, labetalol, because it antagonizes alpha 1, it's going to lead to a decrease in peripheral vascular resistance. Now, for some of you who are weak on Pharm, I have Pharm modules on all this stuff, and I've made clips on it, but you need to know alpha 1 agonism normally constricts peripheral arterioles, increases resistance, increases blood pressure. So if you antagonize alpha 1, you're decreasing peripheral vasoconstriction, you're increasing diameter of peripheral arterioles, decreasing afterload on the left ventricle. Okay, so you can see that difference in peripheral vascular resistance between propranolol and labetalol. They ask these as separate questions on the step 1 NBME exams. Okay, so you have to know that. Okay, so we talk about more of the 2CK level 3 stuff. Actually, I shouldn't say that in isolation because they do ask this on step 1, that for heart failure, the first drug they want is ACE inhibitor or an angiotensin 2 receptor blocker before beta blocker, okay? And I'll ask students, why do you think that is? And it's not just the remodeling effect on the heart. It's because if you have heart failure, you're going to have reduced perfusion to the kidneys, which is going to increase RAAS. So angiotensin 2 is a potent vasoconstrictor of peripheral arterioles. So if you knock out RAAS by giving an ACE inhibitor or an angiotensin 2 receptor blocker, you decrease afterload in the left ventricle and you allow for an improvement of ejection fraction. So they like ACE inhibitors or angiotensin 2 receptor blockers. ACE inhibitor as in lisinopril, they really like that one. Okay, that tends to be the drug they mention. ARBs such as candesartan. Then after, you can move to a beta blocker such as metoprolol. Propranolol is not classically used for heart failure. That's something else you should know for level 2 stuff, is that if sometimes you get a question, it's a heart failure question, let's say, and you're not sure whether the beta blocker should be given, and they list propranolol, you're like, yeah, that's their way of saying it's definitely wrong, because we don't tend to use propranolol for heart failure. We tend to use drugs like metoprolol. And then I'm just mentioning metoprolol tends to be the first drug used for rate control and atrial fibrillation. I said, if you can't give beta blocker for rate control in AF, you can give verapamil. So metoprolol tends to be the drug they use for rate control in AF. Beta blockers can cause depression. It's on one of the psych forms for 2CK. They'll just say like patient was started on a beta blocker 8 weeks ago and has had 4 weeks of low mood. And you just need to know that that's possible. Okay, and the question is about removing the beta blocker. Okay, but if you've never heard of that before, you're like, oh, I didn't know that they could cause depression. Okay, so also sexual dysfunction. So lung disease, I mentioned the whole thing with asthma before. Even beta 1 selective beta blockers, you have to be cautious. Okay, because beta 2 is what agonizes bronchioles. You say, well, why can't you just use a beta 1 selective beta blocker like metoprolol? Good fucking question. Okay, not my opinion. So it's just some of you gotta know that beta blockers in general you gotta be cautious about, even beta 1 selective. And then psychotic depression makes sense. Beta blockers can exacerbate mood. Dobutamine, I want you to know the mechanism of action of it, okay? Because if I ask some of you prior to mentioning it right now, I say dobutamine, mechanism of action, you're like, no fucking idea, okay? So it's a beta 1 agonist, stimulates heart rate. I don't go into it in detail too much right now because I've made another presentation on cardiac stress tests. But in patients who aren't going to be exercising, and let's say you want to assess perioperative MI risk, rather than doing an exercise stress test, let's say they have osteoarthritis of the hip, or they have a very fragile condition like a very large AAA that you're repairing, and you rather do a non-exercise stress test, a pharmacologic stress test, you can increase the heart rate with a drug like dobutamine, and then you can use an echo to evaluate for ejection fraction. Okay, so that can be one way of doing the stress test. So know that that's the use case. You say, when would dobutamine be used? Stress test, and it's a beta 1 agonist. Amiodarone, so it's a potassium channel blocker. Notice I don't get obsessive over these are the classes of antiarrhythmics and it's a type 3 and all this shit. USMLE doesn't give a fuck, okay? I mean, I'm telling you what you gotta know for the exam, that's it. So amiodarone, potassium channel blocker, and you gotta be aware of its side effects. So Torsade de Pointes, okay? If you speak French, you're like, okay, well, that's not how you fucking pronounce it, but Torsades, TDP. So it's a sinusoidal rhythm that's very dangerous because it can degenerate into fatal ventricular fibrillation. So the type 3s, such as amiodarone, and the type 1s, type 1As in particular, like quinidine, have a high risk of causing torsades, and also drugs like drugs that prolong QT interval, like TCAs, okay, antipsychotics, metoclopramide. Okay, so macrolides, they all prolong the QT interval and can increase the risk of torsades. Amiodarone, grayish skin discoloration, no, it's possible. Thyroiditis, so it can present as hypo or hyperthyroidism. And if you get thyroiditis in the setting of amiodarone where you're hyperthyroid, you'll have decreased iodine uptake in the thyroid gland. That's more of a lengthy endocrine discussion, which I talk about in my PDFs, but you got to know that in thyroiditis such as de Quervain, which is subacute granulomatous thyroiditis, postpartum thyroiditis, aka silent thyroiditis, drug-induced, whether amiodarone or lithium, that you can get hypo or hyperthyroidism, but that if you get the hyperthyroid state with those conditions, you have decreased uptake, okay? Because you have inflammation of the thyroid gland causing release of hormone into the blood. You don't have production of thyroid hormone there. Your production is actually suppressed. And it's used for ventricular tachycardia in patients without coma or low blood pressure. So in patients who are hemodynamically unstable with low blood pressure, or they have loss of consciousness, you're going to do electrocardioversion / direct current countershock. Okay, I talk about that in one of my other presentations on like ECG stuff. Lengthy chat about, we can go on lengthy tangential points about all these things. Quinidine I mentioned before, so it's a 1A sodium channel antiarrhythmic, and you just have to know for USMLE that it can cause torsades and a weird condition called synchonism, which is headache plus tinnitus. That's literally it. So they give you like a pharm question, big fucking paragraph, and they say like, dude was started on some antiarrhythmic drug and he's got headache plus ear ringing, and you're like, what the fuck? And the answer is just quinidine. Okay, I mean, if you've heard it, if it's like you are right now, factoid, it's not a big deal. Okay, so digoxin, I want you to know that for starters, that its two functions are it increases contractility and it slows heart rate. Okay? Now, in terms of the mechanism, you actually don't have to freak out. Okay? If you, to conceptualize it, you can obviously pause the presentation and read this a bit more if you want, but you're blocking the sodium potassium ATPase pump. You are building up and that's going to result in a buildup of sodium within the cell. Okay? And by building up the sodium within the cell, you're going to indirectly inactivate the sodium calcium transporter, where it's not going to want to bring sodium into the cell as a result, and therefore calcium won't leave the cell. So if calcium builds up in the myocardial cell, you get increased contractility, okay? That's more like mental masturbation type of stuff, like school medicine mechanisms. USMLE doesn't really care. I'm just telling you, like, you can be aware of the mechanism, all right? But increased contractility, and then it also slows heart rate. So increased parasympathomimetic effect, okay? Hypokalemia can cause toxicity, so its binding site, digoxin, is for the potassium location for the sodium potassium ATPase pump extracellularly. So if you block that, in the setting of hypokalemia, you obviously have less competition for that binding site. So I mean, that makes sense. When I say if you block that, it's actually, and I don't mention it in this presentation, but it can also rarely cause hyperkalemia. Okay, if you block it and potassium doesn't get into the cell, it can actually cause hyperkalemia, but hypokalemia can cause toxicity. And then you should know that Vincent van Gogh yellow wavy vision can be one of the ways digoxin toxicity presents. Doesn't decrease mortality and heart failure. Okay, so that's a 2CK level 3 detail. So drugs that decrease mortality, ACE inhibitors, angiotensin receptor blockers, beta blockers such as metoprolol, spironolactone, the combination of hydralazine and nitrates. But drugs like furosemide, loop diuretics, and digoxin do not decrease mortality and heart failure. Furosemide is our very textbook loop diuretic for USMLE. It's basically the one they talk about, 19 out of 20 questions. Ethylcrinic acid's the other one, but yeah, you should know that it blocks the apical sodium potassium 2 chloride symporter on the thick ascending limb. So It's the most efficacious diuretic for fluid unloading. Okay, so if a patient has significant peripheral edema or pulmonary edema and you want to reduce their fluid state, make them euvolemic, you give a loop diuretic first. It's most effective, okay? Now, when I talk about drugs that are first line for heart failure, I said before ACE inhibitors or angiotensin II receptor blockers are first line for improving ejection fraction. You have to use your fucking head when you get a vignette. If you get a 12-line massive paragraph question where 11 of the lines in the question are about how the patient can't breathe and the oxygen sats are low, like the overwhelming focus of the question is, holy shit, there's a breathing problem, then they're going to want furosemide as the answer, not the ACE inhibitor. Okay? If they give you a 12-line paragraph where one of the lines mentions some shortness of breath crackles, but like the 11 other lines are just about heart failure, then that's your ACE inhibitor or angiotensin II receptor blocker is the answer. Okay, so this is what I just mentioned. Okay, so you got to kind of use your head as far as, are they focusing on the heart failure or are they focusing on the dyspnea as to whether you're going to use the ACE inhibitor ARB or the loop diuretic. And then you got to know that loop diuretics cause hypokalemia. Okay, so not only are you blocking potassium reabsorption directly across the apical membrane of the thick ascending limb, but by dropping fluid status, you're also going to jack up your RAAS to compensate, and aldosterone will cause increased potassium secretion distally in the cortical collecting duct, okay? They cause contraction alkalosis. I didn't mention that here, but if you're dropping your fluid status and you kick up RAAS, aldosterone will also secrete protons. It'll dump protons distally additionally. So they call that contraction alkalosis, where your drop in fluid status is in turn causing an alkalosis due to RAAS upregulation. And if they tell you a patient has severe peripheral pulmonary edema, is already on furosemide, and needs a second diuretic now, and this is high yield for step 1 as well, they want the potassium sparing diuretic 14 out of 15 times. Okay, so they might just list some other loop diuretic, some other thiazide. Okay, but thiazide's wrong because thiazide also lowers your potassium. I'll talk about thiazides in a moment, but you need to know that the ENaC inhibitors, such as amiloride triamterene or the aldosterone receptor antagonist spironolactone and eplerenone, those 4 drugs are the ones they want for the potassium sparing diuretics. They ask all 4 on the NVMe exams. Okay, you have to know. I know amiloride, triamterene, even eplerenone, they might sound lower yield. They're not. Okay, they show up. And then loop diuretics can cause ototoxicity, tinnitus, vertigo. USMLE likes loop diuretic and thiazide effects on calcium. Okay, so loop diuretics are going to increase urinary calcium. Thiazides are going to decrease. So the way you can remember is it's exceedingly high yield, you know, that thiazide diuretics increase calcium reabsorption because they are often used to decrease recurrence of calcium stones. So if you remember that thiazides pull calcium out of the urine, then you can say, okay, loops do the opposite. So loops are going to increase the calcium in the urine. Okay, that can be one way to remember it. And then, as I said before, ethacrynic acid is another drug you should be aware of. It's a loop diuretic. It's not a sulfa drug. Okay, it's still ototoxic. So hydrochlorothiazide, that's your classic thiazide diuretic there. And then you need to know the mechanism of action is that thiazides block the sodium chloride symporter on the apical membrane of the early DCT. It's amazing to me how many med students don't know the mechanisms of action of loops and thiazides, who like are scoring decently. Okay, so you just got to know those MOAs. And as I mentioned with the calcium, there's even a question floating around where they ask for the mechanism of action of a thiazide, of hydrochlorothiazide, and inhibition of the sodium chloride symporter in the early DCT isn't even listed. They just list increases. I wrote decreases calcium reabsorption there. That should say increased calcium reabsorption. Okay, so that's an erratum. That's annoying because there's going to be a fraction of people who like see the slides or are watching this on mute. There's going to be some fraction who will be like, Mike, it should say increased calcium reabsorption. You're right, they increase calcium reabsorption, but it's fucking annoying. I'm not going to restart the whole fucking presentation, am I? Okay, but you got to know that thiazides increase calcium reabsorption, not fucking decrease. Okay, I just harped on it, and I got to deal with that later. I got to remember to change that. So, as I mentioned a bit earlier, thiazides and dihydroproteinate calcium channel blockers like nifedipine and lodipine, these drugs are used for hypertension in patients who, quote unquote, don't have other problems. So if you get a patient who has prediabetes, diabetes, any evidence of atherosclerotic disease, intermittent claudication, angina pectoris, any structural heart disease like cardiomyopathy, you're going to use ACE inhibitors or ARBs first for the hypertension. You're not going to use a thiazide or dihydroproteinate calcium channel blocker. Okay, so there's one question floating around where you got to know that in diabetes specifically, that if a patient, did I write this already on? Yeah, so I'm just letting you know that you want to be careful adding spironolactone in a diabetic. There was a question floating around where spironolactone was wrong in a diabetic, okay? And so yeah, you just got to know that that can cause renal issues. So it can cause hyperkalemia. I just threw it in here. I want you to know that. Okay, so be careful using spironolactone in diabetes because there's a 2CK question where it's wrong. Essentially, when we're talking about the hierarchy of drugs to give in heart failure, ACE inhibitor first, then beta blocker, then spironolactone, that tends to be the sequence. But the 2CK question, rather than going ACE inhibitor, beta blocker, then spironolactone, they had thiazide after, which was really fucking weird. But as I said, you want to be careful using spironolactone in diabetics, cause hyperkalemia. Okay, so there used to be a mnemonic, and I've even mentioned it before, called hypergluc, G-L-U-C. Hypergluc being hyperglycemia, lipidemia, uricemia, calcemia as the potential adverse effects of thiazides. And that's why we tend to avoid thiazides in those who are pre-diabetic or diabetic, okay, because they can increase the sugar levels. And that's why it was weird, that last question, where they go to a thiazide instead of spironolactone. But for USMLE, it's to my observation, you got to know that thiazides can cause gout. Don't be surprised if you see that. And then also there's an offline NBME 20 question where there's milky discharge from the nipples in a patient who's on thiazide, and the answer is adverse drug effect. Okay, and if you search the literature, it's like impossible to find it. It's like 0.2% of side effects of thiazides or galactorrhea, but it's asked on one of the NBME exams. So amiloride, triamterene, those are your potassium-sparing diuretics. They inhibit ENaC, okay, so decrease sodium reabsorption distally, prevent water reabsorption because water follows sodium. And these indirectly inhibit the sodium-potassium ATPase transporter on the basolateral membrane of the cortical collecting duct. It's a long discussion in terms of the physio, but that's ultimately why they're potassium sparing, okay, because you have the sodium-potassium ATPase pump reabsorbing sodium, secreting potassium. But if you block ENaC on the apical membrane, you're going to indirectly shut it off. Doesn't fucking matter, okay? What matters is that you just know amiloride, triamterene, those are not only ENaC inhibitors, but they're potassium sparing, and that either one of those can be the answer if the patient's already on a loop diuretic and you need to add another diuretic. As I just fucking said, okay, they're not going to drop your potassium too much. And then spironolactone, eplerenone, same deal. They're aldosterone receptor antagonists, and they're gonna that's their mechanism where they're going to lead to decreased sodium reabsorption. Okay, so they indirectly will shut off ENaC on the apical membrane, and because they're potassium sparing, they can be used after furosemide. Okay, because you don't want to give two diuretics in a row that cause hypokalemia. And then I mentioned before that when we talk about the hierarchy of, we do ACE inhibitor ARB first for heart failure, followed by beta blocker, followed by spironolactone. Okay. And then you can also use for aldosteronoma, Consyndrome. It's on one of the NBME exams. So they'll give you a patient who has low potassium, high bicarbonate, high blood pressure, so that's high aldosterone. That sodium can be normal. Okay, it's classically increased, but it can be normal in NBME questions. I made another presentation talking about that. And they'll say aldosterone to renin ratio is high, which means it's not renal artery stenosis or fibromuscular dysplasia. So you say, okay, it's primary adrenal, such as Conn syndrome, which is aldosterone secreting tumor, and then they ask for the drug you give, and the answer is spironolactone. Spironolactone is anti-androgenic and causes gynecomastia. Eplerenone has lesser risk of gynecomastia compared to spironolactone. Lisinopril ACE inhibitor, this is the USMLE favorite for the exam, the one that tends to show up all the time. Obviously, there's others like enalapril, captopril, and then it's used for patients who are pre-diabetic, diabetic, atherosclerotic disease, renal disease, any proteinuria, any increased creatinine or renin, you give ACE inhibitor, okay? Some students can get pedantic and say, don't you avoid ACE inhibitors or ARBs in patients who have bilateral renal artery stenosis? The answer is yes, okay? But I'm talking about the overwhelming majority of patients who just, you got a 55-year-old white dude who's got high sugar levels, you will give lisinopril, okay? Overweight 60-year-old white woman who's got some proteinuria, her sugar levels are normal, well, you're going to give an ACE inhibitor, such as lisinopril, okay? So carotid stenosis, patient has high blood pressure with stroke, TIA, retinal artery occlusion, lisinopril is the drug they want, okay? ACE inhibitors can cause dry cough, and it's because ACE is also known as bradykinase, so if you knock out that enzyme, you get a buildup of bradykinin. Something about the vasodilation in the lungs that increased bradykinin results in increases the propensity for dry cough. And then ACE inhibitors can increase your potassium levels, makes sense because you're decreasing aldosterone synthesis, okay? So angiotensin 2, one of its roles is it goes to the zona glomerulosa of the adrenal cortex and upregulates aldosterone synthesis, okay? So you're knocking that out, you're gonna retain potassium. And then some detail is you avoid an hereditary angioedema. I'm kind of like, I roll my eyes at that because that's a detail like students who aren't even passing the NBME exams might know, but then they like don't even know what like angiotensin 2 does, but they like know that you shouldn't use it in hereditary angioedema ACE inhibitors. Okay, so valsartan, I just listed a common angiotensin 2 receptor blocker, and the use case for ARBs and ACE inhibitors are identical in the USMLE, except that they don't cause dry cough. And the reason it's important that you know their use cases are identical is because if you see them listed as separate answer choices, they're almost always both wrong, okay? They're not really going to be like, which one causes a dry cough? And it's like lisinopril, not valsartan. They don't do that. Like they'll be asking you for what drug you're going to use in a situation. And if you see them as separate answer choices, they're both fucking wrong, basically always. Phenylephrine, oxymetazoline, you need to know that these are alpha-1 agonists, okay? So these constrict arterioles, it's going to increase blood pressure, and then baroreceptor reflex. Heart rate goes down to compensate, okay? So you just have to know that physio. So I'm relating that to cardio, right? Because it's a cardio presentation, but interestingly, they're not even really used for cardio. I mean, unless they tell you like an anesthesiologist is giving a drug that increases blood pressure, heart rate goes down, they give it to you in like a graph form, like drug X, drug Y, and you have to like sit there and fucking figure out and discern what drugs they're talking about. But in clinical, like real clinical use in real life, they're actually used intranasally to decrease nasal congestion. So when you have a cold and you use an intranasal spray, and you go into the pharmacy, you're like, hey, do you have anything with like phenylephrine or oxymetazoline? Like you can ask that, okay? And that's what you're looking for to decrease your nasal congestion. You should also know, I didn't write it here, but they decrease nasal bleeding as well. Okay, it makes sense if you're constricting the capillaries within the nasal mucosa. And then there's something called rhinitis medicamentosa that you just got to know that you can get rebound nasal congestion. So desensitization to them and rebound nasal congestion if you use them too long. Isoproterenol. This drug is similar to dobutamine in the sense that USMLE wants you to know the mechanism of action. So we said dobutamine was a beta-1 agonist. Well, you say, oh, isoproterenol, what's that? You just say that's a beta-1/2 agonist. Okay, so if it's a beta-1 agonist, it's going to increase heart rate. And if it's a beta-2 agonist, it would also dilate peripheral arterioles, decreasing resistance. And I say just know the MOA in physio because this is a perfect example of one of those drugs that they can give to in graph form, drug X, drug Y, and then you have to like figure out what's going on with whatever they're asking you. Methyl dopa, clonidine, these are alpha-2 agonists. Okay, so you got to know their mechanism of action. Methyl dopa can be used. So Alpha 2 is a sort of an odd one out receptor in that it's a negative feedback receptor on presynaptic terminals. So by agonizing it, you decrease the release of neurotransmitter, especially norepinephrine and serotonin. So methyl-dopa, its use is in pregnancy classically. It's an agent for hypertension. Nifedipine, labetalol also used. And then clonidine is an alpha-2 agonist that can be used in psych for Tourette. It's a little bit weird, don't tell you, but just know their mechanism of action in those two use cases. And then hydralazine, USMLE wants you to know the physio. Okay, so they can tell you in a vignette, hydralazine's given, and which the following is gonna, like, where would it act? And the answer is arterials, whereas veins is wrong. Okay, and decreases blood pressure, heart rate goes up to compensate. All right, and I mentioned earlier, because I didn't write it here, I mentioned earlier that the combination of hydralazine and nitrates decreases mortality and heart failure. So we go ACE inhibitor ARB, beta blocker, spironolactone, hydralazine, and nitrates up the hierarchy. And then they don't give a fuck about its mechanism of action being calcium currents, but I'm just telling you because you're like, well, what does it actually do if it's dilating arterioles? Literature says it affects calcium currents, but it's not directly a calcium channel blocker. But USMLE is not going to ask, as I said. They just want you to know it dilates arterioles, and it can be used for hypertensive emergencies of pregnancy. I didn't write it here, but it can also cause drug-induced lupus with antihistone antibodies. Nitrates, USMLE really wants you to know the mechanism of action. Okay, so nitrates upregulate guanylyl cyclase, increase cGMP, increase protein kinase G, and that's going to lead to relaxation of vascular smooth muscle within the veins, and that increases venous pooling, which is going to decrease preload on the heart, and that decreases oxygen demand, and it relieves your inguinal pain. Okay, so they can just tell you, easy question, pass level, as I said, but they'll tell you dude has angina pectoris and takes a sublingual drug under his tongue, and they'll say which the following is most likely to occur in this patient to relieve his pain, and the answer would just be like choice C, increase cGMP. Not dramatic, okay? Don't combine with phosphodiesterase 5 inhibitors such as sildenafil, because phosphodiesterase 5 inhibitors prevent the breakdown of cGMP, so if you have nitrates which upregulates cGMP, you can get hypotension. Okay, and as I mentioned before, hydralazine and nitrates together decrease mortality and heart failure. What they might do in a 2CK stem is give you a big fucking paragraph. The patient's on like 7 drugs, and you notice one of them is hydralazine, and that kind of strikes, you raise an eyebrow to it, because that's not a typical drug you see in a stem, right? So you see the hydralazine there and say, which of the following could be modified in this pharmacologic regimen to improve mortality? And the answer is add isosorbide dinitrate. It's like, ooh, shit, okay. Hydralazine nitrates together, all right? That's how they can ask it. And then I'm just mentioning that nitrates primarily act on the veins. Choose veins for nitrates, but for nitroprusside, choose the arterioles, all right? And it can be used for hypertensive emergencies. I said as for dissection and traumatic rupture of the aorta, choose labetalol first before nitroprusside additionally. Statins, okay, so they inhibit HMG-CoA reductase, the rate-limiting enzyme in cholesterol synthesis, and that's what you guys will, at least you should know, okay? But then you might get a question where they ask you for the mechanism of action and it's not listed. You're like, what the hell? But then the answer is increased LDL receptor expression on hepatocytes. So by inhibiting cholesterol synthesis within the liver, what's the liver going to do? It's going to compensate by pulling it out of the blood. So it does that by upregulating LDL receptors. Now this is annoying because for like basically the past decade plus, it was harped on that hepatotoxicity. It was a factoid we had learned back in the day, especially for the numerical step 1, okay? That even though statins can cause myositis, rhabdomyolysis, myopathy, that OMG, hepatotoxicity is actually more common. Okay, but there's a question on one of the new NBME exams where they say a statin is given and what's most likely to occur in the patient, and the answer is myopathy, where toxic hepatitis is wrong. Okay, and then the term toxic hepatitis, if you go searching on the internet, you say, well, is that specific? Is that why? Are they talking about like fulminant hepatitis or something? The answer is no. I mean, the term can be applied to increase LFTs in general. I didn't write it in this presentation, but you should know that if you start a statin and there's a slight elevation of LFTs, you don't have to decrease the dose or stop the statin, okay? So mild transaminitis is normal and expected in with agents that are hepatotoxic. So, and you got to know that the combination of statins with fibrates further increases the risk of myopathy. And it's an answer on one of the NBME exams where it's a P450 interaction. That's what they want. Now, if you're saying for 2CK3, okay, you just got to know real quick that the indication for giving a statin is LDL greater than 190 if you're 20 to 39, and then if you're 40 to 75 if it's greater than 100, and then in any diabetic patient, 20 to 75 if it's greater than 100. Okay, so you don't give statins under 20, basically always. Certain very rare instances, let's say hypercholesterolemia, they can be applied, but these are the guidelines you have to know. And then I'm just pointing out that some guidelines, depending on where you look, will actually use 70 as a cutoff rather than 100 for these guidelines here. But I'm letting you know, as per my observation on the USMLE, that they want 100. Because there's an NBME question, I've seen where they'll give a 95 and giving a statin's wrong. So under 100 is actually what they're okay with for the exam. And then some students get pedantic, and that's because about the cardiovascular disease risk percentages as far as low intensity, high intensity statins, et cetera, and whether we give a statin at all. And I think that that's because QBank tends to focus on that. USMLE doesn't give a fuck, okay? Fibrates, so these are the best drugs to decrease triglycerides, and you're going to give them if triglycerides are greater than 300. Now, they upregulate lipoprotein lipase and PPAR alpha. So I said before that lipoprotein lipase is the enzyme that's deficient in hyperchylomicronemia. Okay, so this enzyme is going to allow for triglycerides to move from the blood into the adipocyte. So if you upregulate that enzyme, well, you're going to decrease TGAs in the blood. Okay, so same as statins, they can increase the risk of myopathy and hepatotoxicity, but they have the additional side effect of causing cholesterol gallstones, which does show up on the NBME exams, okay? So, and I mentioned before the P450 interaction, and then ezetimibe, they want you to know the mechanism of action. They'll make it very easy. They'll just give you a paragraph, and they'll say in the last line, ezetimibe is prescribed, which of the following is the mechanism of action. It's literally that straightforward, and the answer is just decreases small bowel absorption, okay, of cholesterol. And it doesn't decrease mortality. So drugs such as ezetimibe, bile acid sequestrants, which I'll also talk about, there are drugs that decrease LDL, but do not decrease mortality the way statins do. And it's believed because that is the case because statins have an antioxidant effect on arterioles and vascular endothelium that transcends the lipid lowering effect, that it's actually the antioxidant effect that is more important for improving mortality, or for, I should say, for decreasing mortality rate. So cholestyramine, that's your bile acid sequestrant. So these will bind bile acids and prevent their reabsorption in the terminal ileum. So if you block their reabsorption, then there's fewer bile acids back up top at the liver. And so the liver has to make more. The way it does that is it converts cholesterol into bile acids. So if it uses cholesterol to do that, it's got to pull more cholesterol out of the blood to compensate. Very fancy mechanism that USMLE actually doesn't give a fuck about. I'm just mentioning it, okay, because, conceptually it can help you remember. Orlistat, it's pancreatic lipase inhibitor, can cause steatorrhea. It's asked on one of the NBME exams. Niacin, vitamin B3. So they want you to know these two mechanisms of action. So niacin will increase HDL more than any other medication, and it decreases VLDL export by the liver. Okay, so they just ask that straight up. And it's very high yield. You know that niacin can cause flushing, which, because aspirin can mitigate the flushing / prevent it if you co-administer, that tells you the flushing is the red face is caused by prostaglandin and not histamine. Okay, if they ask. Niacin can also cause gout. They ask that on the USMLE. They'll give you a patient who has a history of podagra, gout of the big toe, and they'll say which of the following is contraindicated in this patient. The answer is niacin. And then also niacin can exacerbate sugar levels in diabetics. This is why we don't routinely give niacin clinically. They had done some major study many, many years ago where there were patients who were on statins only and then patients who were on statins plus niacin. Because you say, well, if it increases HDL more than any other medication, high HDL is good. Why wouldn't we also give niacin routinely? And it's because of major adverse effects. A lot of patients getting flushing, okay, patients getting gout, diabetics having worsening sugar levels, pre-diabetics were pushed into diabetes. And then deficiency, I sort of am going on a tangent real quick, but you should just know deficiency is called podagra, okay, dementia, dermatitis, diarrhea, and that one of the new NBME questions, they give you Casal necklace, so just dark hyperpigmentation, sun-exposed areas around the neck. That's very textbook, but it also shows up in the USMLE. The hyperpigmentation is just darkening of the skin in the forearms. Doesn't have to be Casal necklace. And then rather than giving you dementia, they can actually give you delirium. So they'll say, dude, in hospital, he has visual hallucinations bouncing off the walls. He has increased bowel motions, and he has hyperpigmentation in the skin of the forearms. Which vitamin is deficient? You're like, what the hell? Well, if you know that the biggest risk factor for delirium is underlying dementia, then it's not so hard because the old patient, 85-year-old granny, is more likely to get delirium, let's say, from having surgery than a 20-year-old male. Okay? Procainamide, so it's a 1A, it's a sodium channel blocker, and the only thing you need to know for USMLE is just number 1, block sodium channels, number 2, it can be used for Wolff-Parkinson-White, number 3, antihistone antibody, so similar to hydralazine, can cause drug-induced lupus, okay? Flecainide, so it's a 1C sodium channel blocker, and this, if rate control fails for atrial fibrillation, so we metoprolol or verapamil. If the patient fails rate control and we go to rhythm control, we can use flecainide, all right? And the patient can't have any structural or coronary artery disease. We're talking more like 2CK level 3 stuff, but you could say, when is flecainide used? Well, there you go. And then we're just going to end on this real quick, a bit soft, just the omega fish oils, okay? They ask it on one of the NBME exams, okay? So they'll just say, like, a patient started taking a supplement with fish oils, on which the following is most likely to be seen in this patient, and the answer is decreased triglycerides. Okay, so you do have to know a fish oil for USMLE. All right, so that's your cardio Pharm Dyslipidemias presentation. Obviously, I'll make more clips and subscribe to my channels, and I appreciate your time. That's it.